my name is McIntosh, and today I will be presenting on mesothelin-specific chimeric antigen receptor T cells induce anti-tumor effects in solid tumor malignancies with addition of the PD-1 checkpoint blockade. Solid tumor malignancies are abnormal masses of tissue that usually do not contain cysts or liquids. These tissue can be either benign, which is non-cancerous, or malignant, which is cancerous. The name of these tumors are dependent on the tissue that it affects. Some examples of solid tumors are sarcomas and carcinomas, and some examples of non-solid tumor cancers are leukemia or cancer of the blood. More than 12 million people every year are diagnosed with cancer, and more than 7 million deaths result from cancer. One reason this is so important is because there is a difficulty in fighting solid tumor malignancies. Immunotherapy has shown to be successful in non-solid tumor cancers and diseases, and so there is a possibility that immunotherapy could be an option for treating solid tumor malignancies in the future. One obstacle that treatment has to overcome is the tumor microenvironment. This microenvironment consists of blood vessels, immune cells, fibroblasts, and extracellular matrix. The purpose of the microenvironment is to ensure growth and survival of the tumor. Angiogenesis is one means of growth and survival, and it is the production of blood vessels. Tumors are able to produce blood vessels from already existing vessels, as seen in this figure, in order to provide blood supply and nutrients to the tumor. There are treatments that are anti-angiogenesis, but the issue with that is a lot of treatments require these blood vessels and these vessels to get the treatment to the tumor adequately. Another means of growth and survival is that the microenvironment is immunosuppressive. There is a high amount of anti-inflammatory cytokines and T-regulatory cells present that prevent the immune system from acting on the tumor cells. Both of these defenses act against the immune system in tumor treatment. Mesothelin is a glycoprotein that is on mesothelial cells. Mesothelial cells are slippery, non-adhesive cells, and some examples are the lining of the pleura, peritoneum, and ovarian and pancreatic cavities. Though its function is not completely known, mesothelin is seen to be a possible adhesion molecule. It is overexpressed in 30% of cancers. While this is not a large percentage of cancers, it is overexpressed in a high percentage of mesothelial tissue cancers. Researchers believe that this mesothelin, it being a possible adhesion molecule, aids in migration and invasion. To test this, Cervez et al. Looked at mesothelin expression and cell invasion. What they found is that in a cancer cell line, as seen on the right, mesothelin positive cancer cells had a higher rate of migration and invasion than mesothelin negative cancer cells. To further support this finding, they used mesothelin, natural mesothelin expressing cells, found here on the left. They silenced mesothelin in some of the cells, and what they found is that the cells that had mesothelin silenced had lower amounts of migration and invasion than the cells that had mesothelin still naturally expressing. This further suggests that mesothelin is important for migration and invasion. CAR T cells are engineered T cells that are aimed to increase effector T cell function. These T cells have three domains: a transmembrane domain, a hinge, and an endodomain. The hinge is the actual binding domain of the CAR T cell. There are three generations of CAR T cells. First generation, which just has a CD3 zeta subunit, and the second and third generations have CD3 zeta along with other co-stimulatory subunits added. These CAR T cells have been shown to be successful in some lymphomas and other lymphatic diseases. Mesothelin specific CARs would bind specifically to mesothelin on cancer T cells. This could provide to be a possible immunotherapeutic treatment for solid tumor malignancies. In this figure, and I apologize I was not able to find a clearer figure, by Jang et al., they were looking at growth suppression in pancreatic cancer with the addition of mesothelin CAR T cells. What they found was that when they were treated with these meso-CAR T cells, there was a significant amount of tumor growth suppression than when not treated with either of these lines of mesothelin specific CAR T cells. Another obstacle for this treatment is the PD-1 checkpoint. PD-1 stands for Programmed Death Protein 1. Its ligands are PDL1 and PDL2. PD-1 is located on T cells and B cells, and PDL1 and 2 are located on antigen-presenting cells. Their purpose is this interaction purpose is to prevent autoimmunity. What happens is that when PDL1 and PD-1 bind, it signals for a lower proliferation of antigen-specific T cells and a reduction in apoptosis of Treg cells. This prevents a reaction to a self-antigen. In terms of cancer, tumor cells actually have an upregulation of this PDL1 ligand. The purpose of that is to inhibit the T cells from acting against the tumor. There are methods to create a blockade to this PD-1, PDL1 checkpoint. One method is a PD-1 antibody. These antibodies are directed at PD-1 to prevent it from binding to PDL1. Another blockade would be using a DNR, or a dominant negative receptor, which would bind to the PDL1, preventing the PD-1 from binding, and that in turn prevents the inhibition of the T cell. In this figure, Cherkassky et al. Were looking at mesothelin specific CARs and PD-1 checkpoint and resisting inhibition. What they found in the first two figures, in both of these CAR T cell lines, that the addition of PDL1 actually had a lower amount of CAR T cells present than with just mesothelin present alone. In this third figure, they look at CAR T cell treatment along with a CAR T cell treatment and a PD-1 blocking antibody. What they found is that the addition of the PD-1 blocking antibody significantly increased the amount of CAR T cells present in comparison to the CAR T cell treatment alone. There have been clinical studies done using these two different methods of the meso-CAR T cells and the PD-1 inhibitors. One PD-1 inhibitor study used an anti-PD-1 antibody. What they found is that there was an increased T cell counts in the microenvironment of lymphoma patients that received this anti-PD-1 antibody. In the meso-CAR T cell study done by Tani et al., they saw that there was malignant cell clearing in the pleura, which suggests that there is direct anti-tumor effects from the meso-CAR T cells. There are no clinical studies done with meso-CAR T cells and anti-PD-1 as of right now, but it is important to look at similar studies to get an understanding of what this would look like. So, Heskey et al. Looked at GD2, which is a neuroblastoma protein, specific CARs, and a PD-1 inhibitor, which is shown in this figure. Cohort 1 just used the CARs, Cohort 2 used the CARs and chemotherapy, and Cohort 3 used CARs, chemotherapy, and anti-PD-1. What they found is that CARs with chemo had more expansion, long-term persistence, and IL-15 than CARs alone. The PD-1 inhibitor did not seem to have a significant difference from just the CAR and chemotherapy treatment together. They said that this could be due to this being a pediatric study and that there were not enough neoantigens in pediatric patients for a PD-1 inhibition to have an effect. However, notably, the two patients that reached full complete remission were from Cohort 3, which included all three of the treatments. So meso-CAR T cells and PD-1 checkpoint blockade may increase the effectivity of current treatments for mesothelial cancers. The future goal is to be able to treat solid tumors with immunotherapy effectively. Some limitations to the specific treatment is that some mesothelin could be found soluble. To prevent CAR T cells from binding to the soluble mesothelin, sequences that are only found in membrane-bound mesothelin are being used to direct the CAR T cells to that mesothelin and not the soluble. On target off-tumor targeting is when the CAR T cells bind to a normal cell expressing mesothelin and not cancer cells. This is where the PD-1 checkpoint would come in play to prevent that CAR T cell from activating and fighting against normal cells. Per the last study, the effectivity of the PD-1 blockade and CAR T cell therapy in vivo together is not certain, but with further research, it could be proven or disproven that it would actually work. There are also other checkpoints like CTL4 that are used to downregulate immune responses, and those are also in effect, and not just the PD-1 checkpoint. Even though with those limitations, this has shown to be a promising line of research in being able to treat solid tumor malignancies with immunotherapeutics. Thank you.